All right, so welcome everyone to our monthly psychology grand rounds. Before we get started, just a few housekeeping items. So first off, if you have any questions for our speaker, Dr. Root, please post those to the Q&A and those will be addressed and answered at the end of the talk. And then for psychologists who are attending this lecture, the CE attestation link will be posted to the chat. And just look out for this. The link's going to be valid for 1 hour following the lecture. And, it'll be your responsibility to look out for that link and to complete it within the designated time frame. That being said, it is my tremendous pleasure right now to introduce our speaker, Dr. James Root, who's going to be talking to us about cancer-related cognitive dysfunction. Dr. Root is an attending at Memorial Sloan Kettering. He's a professor of psychology in the Department of Psychiatry at Weill, Cornell. And his clinical expertise is in the assessment of cognitive abilities in adults following cancer diagnosis and treatment. And his research focus is the cognitive impact of cancer diagnosis and treatment within the neurocognitive research lab. And he uses neuropsych data, neuroimaging, psychophysiological assessments to investigate the effects of cancer and cancer treatment on cognition, brain structure, and brain function. And so, Dr. Root, we're really excited to hear from you. And thank you again for agreeing to talk to our group today.
Oh, sure. Thank you for introducing me, Christina. So I'm seeing 4 panels here. Are there other people on, or?
Yes, no, we have 33 people here, so you're fine. But if you could share the screen and
Sure.
we can get started.
Yep. Just 1 second. Okay. Okay. Can you see that?
Yep, we can.
That's great.
All right. Well, thanks for having me. Yeah, so I was at Cornell and now I'm at Memorial Sloan Kettering. And for the past 14 years or so, I've been along with Tim Ollis, who's one of the early people in the field of cancer and cognition. We've been looking at cognitive outcomes in cancer survivors. And I see people both clinically, and then we have a number of research projects ongoing and just completing that I'm going to be talking about today that aim to kind of understand better the cognitive mechanisms and improve measurement of cognition in cancer survivorship, because it kind of poses its own unique challenges, I think, which I think will become clear as we go through. I'm mostly getting a cold, one of the two, so forgive me if I'm clearing my throat a lot, but I'll try not to. So I'm going to talk about today, it's really peripheral cancers. So I'm not going to be talking about CNS or primary brain cancers, but really, breast cancer, colon cancer, those kinds of cancers that are more peripheral and are treated systemically, and trying to understand the nature of patient-reported or survivor-reported cognitive complaints post-treatment and in the years following that. Let's see. So the first thing to know, if you've heard anything about cancer and cognition, is this notion of chemo brain or chemo fog. And while we think chemotherapy definitely plays a role, we really shifted to calling this cancer-related cognitive dysfunction for a few reasons. One is that in a lot of our studies, we don't see a significant effect of chemotherapy over and above non-chemotherapy treated, hormonal therapy treated breast cancer patients, as an example. So not to say it doesn't play a role, but it just seems like it's a much larger kind of what we kind of refer to as the package of cancer and cancer treatments that people are exposed to that that have some cognitive outcomes. So there's other potential factors that we need to kind of take into account. One is some people have thought about a shared risk for cognitive decline in cancer, meaning that people who are more likely to develop a cancer might have also a shared genetic risk for cognitive decline due to things like maybe oxidative stress and DNA repair mechanisms and so on that might lead to parallel outcomes. So they're not really one causing the other, cancer causing cognition, but they might be parallel outcomes given some baseline genetic risk. Another one is the stress of diagnosis and treatment. I don't mean just the reactive anxiety to diagnosis and treatment, but more kind of a Bruce McEwen allostatic load animal model of stress, looking at chronic restraint stress in mice. You can see atrophic changes in the brain, hippocampal atrophy, and so on. So that's something to take into account. These individuals are going through kind of a parallel experience of chronic stress from day to day, sometimes for several months, even to years. I just published a paper just recently looking at tumor markers. So volume, stage, grade, HER2 positivity, molecular attributes of the tumor that seem to be associated with cognition even before any further adjuvant treatment, like with chemotherapy or hormonal therapy. So something about the tumor itself, maybe the microenvironment, inflammation, and these are in tumors that are already resected, but prior to any other treatment, we're seeing some effect of those kinds of tumor markers for poorer cognition. You have the surgical stress. I always think that, we have this whole body of literature of postoperative cognitive decline that we're not really attending to all the time because we think we're studying cancer and adjuvant treatment. But all the individuals, or most of the individuals that we see, are post-surgery and pre any further treatment. So we have to keep that in mind. That aspects of anesthetic exposure or surgical stress can have an effect on cognition. Certainly chemotherapy comes into play. Radiotherapy, even peripheral radiation therapy, can cause kind of global inflammation and potentially neuroinflammation. All the endocrine therapies that we use in breast cancer, tamoxifen and aromatase inhibitors, in prostate cancer, Lupron, that are meant to decrease the hormonal milieu or the hormonal levels of things like estrogen or testosterone, to the extent those play a role in brain function, which we think they do. We are for several years at a time, in the case of breast cancer for 5 years, in the case of some prostate cancers on and off for years, we are reducing those levels, and that can have effect on cognition. And then a focus of our lab right now, more and more in older survivors, is this notion of deficit accumulation and frailty. So the accumulation of various comorbidities, polypharmacy, social detriments of health, that are kicked off potentially later on by our treatments. So hypertension, cardiovascular disease, diabetes, and so on, that might have long-term or later effects on cognition as a result. So, one question as neuropsychologists, I think, we've always wanted to know, there's a profile here, a syndrome, or there's a pattern to the results that suggests one thing or another. And it's extraordinarily difficult, I'll say, in what we study to find that. Although I'm going to give you some ideas about what I think are some commonalities. It's really, to some extent, it seems like it's going to depend on when you do the assessment. So you have, initial diagnosis and cancer-related effects, like we were just discussing. You have post-surgery, which when you have surgical stress and anesthesia, post-adjuvant therapy like chemotherapy or hormonal therapy over shorter time frames of 1 to 5 years. And then, like I was saying, long-term survivorship, 5 to 20 years, when you're looking at potentially deficit accumulation and altered cognitive trajectories of aging in that way, which I'll talk about at the end with a recent RL1 that we just got. So I'll start by talking about the experience of cognitive changes in cancer survivors. I'm not sure how many of you have dealt with cancer survivors in your practice, either psychotherapeutically or assessment-wise, but I'll give you a sense of kind of what I hear from my patients and also what's in the literature. So unsurprisingly, about 100% of patients have acute changes during or shortly after treatment. So no one really gets out of this unscathed in the short term. But more importantly, 50% or more over a longer term, so greater than a year post-treatment, report cognitive changes. So that's in the self-reported cognitive changes. And as you probably know, self-report and objective performance rarely meet. They rarely correlate. And so, and it might be that they're measuring two different things, or it might be that the self-reported cognition is a more sensitive indicator of actual day-to-day cognitive performance. And the common problems reported, and I'll go over this clinical data set in a second, but the common problems reported are forgetfulness. So memory dysfunction in our clinical sample that we looked at for a research project, 80% coming in as a primary complaint for forgetfulness and memory dysfunction. And that can be anywhere from grocery items to appointments, to forgetfulness for intentions, whether it's future appointments or walking into the room, not remembering what you came in for. And most importantly, I think for the focus of what I'm going to talk about, conversations, so what they're hearing. And so I think of this kind of, it's kind of in one ear, out the other. So whether we call this forgetfulness or attention is going to be one key aspect of what we're going to be talking about today. Is there real evidence of forgetfulness, or is it maybe more so that people are becoming distracted and losing focus at the time of encoding that leads to the experience of a memory lapse? Concentration, of course, over longer periods of time, whether it's doing your banking or finances or working on complex projects at work, are more difficult. Multitasking and going back and forth between one project and another becomes more difficult. Word finding, which when I got here, I was surprised to find that this is a common complaint, and it's a lot of probably what you'll be hearing from me today, a lot of halting and a lot of looking for words that aren't coming naturally, and so kind of a tip of the tongue kind of a feeling. And then generally just feeling of being slower and tasks being more effortful. So I'd say survivors typically say, I can still do it, but I'm there for hours after my coworkers go home, or I'm just working well into the night to get something done. And it just takes a lot more effort, and I'm slower at it. So then the question is, that's the self-report. What do we find when we actually test performance? And so what I'm going to focus on here, because forgetting or memory is such a key core complaint in survivors, I'm going to focus on exactly that phenomena, which is they're saying they're forgetful. What do we find when we actually test them? So it's really going to be this kind of dichotomy to some extent of the role of attention versus forgetting in their memory complaints. So survivor studies find some level of cognitive problems about 6 months to 10 years post-treatment, as long out as 20 years. By Vince Koppelman's, there's a 20-year study, cross-sectional, that's showing even persistent then cognitive difficulties or differences in cognition. About a quarter, referencing the paper I was just talking about, have or exhibit cognitive difficulties and cognitive differences after surgery and prior to starting any other treatment. That might be related to tumor aggressivity, like we were just talking about. And then persistent cognitive problems in about a quarter to a fifth of patients, meaning out years post-treatment. And then in a meta-analysis, the majority find longitudinal changes. So that's even controlling for what might be already altered cognition at baseline, which is post-surgery, and then follow up, in 8 months to a year. So like I was saying, forgetfulness is the most common complaint, but it's not a robust finding when we objectively assess it. And that's, I'm saying, mainly in research data sets. In a meta-analysis that's by Heather Jim back in 2012, little evidence was found of true memory dysfunction. And so the question is, why are we not finding that when it's the core complaint of patients? Why are we not finding that when we look at our research data sets? So one is it's difficult to measure. It could also be the fact that we're dealing with a subgroup of people who are truly affected by this. And when we do our research studies, the sorting is just, did you get chemotherapy or hormonal therapy, or did you get breast cancer or not? And we're not making that distinction that there might be a subgroup who are particularly affected. And then we average those signals together, and lo and behold, it washes out. And so the could be there's some genetic risk that increases risk for cognitive difficulties in survivors. And here we're thinking about ApoE4 positivity associated with Alzheimer's disease, COMT associated with dopamine transport, and BDNF with neurogenesis. So it could be some genetic baseline differences that raise the risk for certain survivors to have cognitive difficulties. And then there's deficit burden and frailty, like I was talking about, particularly in our older patients. Are there other comorbidities and polypharmacy and so on? Is there a frailty phenotype there that makes it so that they're already presenting with significant physical or medical risk that's going to, with exposure to our therapies, increase their risk for cognitive difficulties? The other thing is that as a card-carrying neuropsychologist, I think in trying to study this group, what I've realized is that it might be that the neuropsych measures we have available right now, while the gold standard and extremely useful for a number of different conditions, might have some difficulties in sensitivity with the kind of more mild but significant cognitive difficulties that our survivors are experiencing. So these aren't dementia levels of severity or TBI or stroke or CNS metastases or primary tumors. These are the cognitive difficulties that people are experiencing are ones that allow them to keep going to work, allow them to keep dealing with things at home, but they are getting in the way in significant ways in terms of, inconsistent but making errors, being slower, less efficient. And so, it might be that if our standard measures were designed to detect more kind of significant signals, that the measurement error inherent in our measures is kind of dwarfing the noise in those is kind of dwarfing the signal that we're trying to detect. Another reason might be that our standard assessments take place in conditions that are exactly the kind of conditions we tell our survivors to put into place to control their cognitive difficulties, right? We test them in a quiet room free of distraction. The entire testing experience is highly structured, directed by the evaluator. And so that notion of ecological validity, with how much are we really able to say about day-to-day performance based on their neuropsych performance in that kind of setting, might be limited. So this is this clinical data set we put together. And what we did is we said, well, so let's say it's a subgroup phenomenon potentially. So the people who rise to the level of getting a neuropsych assessment are clinically referred, either they're self-reporting or their oncologist or surgeon is saying, okay, well, let's send you over. That's got to be, maybe that's going to be our prototype of this profile. So let's put them all together. In this case, breast cancer survivors, about, I think, 80 or 90 here, clinically referred for an assessment. And what did their learning and memory performance look like? And again, these are 80% who are, that's their primary complaint is memory. And I apologize if this is going over basics, but just for anyone who's not acquainted with a given memory measure, I'll just tell you about this one. This is a CVLT. There's others like the HVLT or NABLIS learning or array verbal learning test. And these are all a set of serial verbal learning tests that are meant to, where we present a list of words, or we say a list of words to the patient, and they repeat them back 5 times in a row. And then we ask them to recall the information shortly thereafter, and then about 20, 25 minutes after that. So I would say like this is kind of the learning section of it here. And then here I would call is the actual memory section. So what are they recalling? And particularly this point here. So based on clinical observation of just seeing these patients, the first, I don't know, a few months I was here compared to the patients I was seeing at Cornell, I was giving everyone a clean bill of health because I wasn't seeing exactly what the difficulty was in the testing. And then I started to notice something that led to us looking at this as a totality of patients that were referred. The serial verbal listening test, Jacques Donders had done a factor analysis on the normative data of this to say, are there any kind of prominent profiles that are popping out of this, that are categories of performance? And so we came out with the kind of the typical profile, right? That there's kind of around their working memory buffer, they get more and more information over time by trial 5, and they retain and recall information just fine. There's a forgetting profile where they might start off fine, they might get up to a certain level, but that they rapidly forget that information by the long delay. And then there's this inattention profile, or as Donders called it, a slow starter profile, which is they start off poorly compared to the normative expectation, but then they're able to compensate for that through repetition, and they can retain and recall the information just fine. Now, there's other profiles in here, but I'm just giving you the 3 kind of prototypical profiles that he had come out with. So what we see when we take all of our breast cancer patients who are clinically referred for assessment, and we look at their learning and memory performance, I used the factor analysis that he used. I won't go into the variables that go into it, but suffice to say, this is essentially trial 1 and a couple other variables. This is the actual recall of information, and then this is like the recognition memory errors. And what you see is that compared to normative expectations, the survivors who are clinically referred are having difficulties with the initial encoding of that information, or registration, or initial learning. We kind of struggle with what to call that, but it's essentially a working memory attention portion of that. But that by their delayed recall, because of that repetition, potentially, they're recalling information at normative expectations. And so what I also did here is just to take this panel as an example, long delay versus trial 5. So this is 20 minutes later, what's their performance compared to the last time they heard that information and repeated it back. So you look at, so this is subtraction, and the gray is clinical and the black is normative. So this is looking at forgetting rates. And you can see that they're not really different from the normative data. So they're not rapidly forgetting information, or forgetting information at a greater rate than the normative data. So this is our first indicator that there was some learning deficit here, or working memory deficit here, that might explain later memory complaints. And also, by the way, why we're not seeing memory as a prominent signal in our research data sets, because if you're only focusing on, if you're only calling this your memory score, then you're going to miss all of this initial trial problems, compensation that leads to a normative score. And so we said, well, okay, that's in clinically referred breast cancer survivors. What does it look like in a research data set? So we had an old data set lying around, and I decided to apply it to that and see if we get anything. And so these are 113 breast cancer survivors with matched controls, all on endocrine therapy at the time that we assessed them. And we looked at a similar thing, a serial verbal listening task. In this case, it was both verbal, and then we had a visual analog to that. And we found the same pattern. So now this is a simplified model from Donders, where we're just taking trial 1 performance here, trial 5 performance here. This is long delay free recall and recognition, or memory errors, but it's false positives. And what you see again is the same signal, right? Trial 1 is where they're furthest off from the controls. By trial 5, they've compensated for that deficit through repetition. And by recall, they're performing at or above control level performance, at least descriptively. So it's a nice replication of that initial finding. What we then did is we decided, well, let's stratify our breast cancer survivor group, and by looking at performance on tests outside of learning and memory, so trials A and B and FAS and animals and all sorts of other non-memory tasks, and let's stratify them to the higher performing versus lower performing survivors and see how strong or robust this signal is. So this is our higher performing breast cancer group, and you see the same pattern, right? In this case, you see actually somewhat of an increase in the delayed recall, but you see, again, you see this finding here, the initial learning deficit. In the lower performing group, you see just an exaggerated pattern. So you see that same initial learning problem, but even through trial 5 and compensation and so on, they're still lower on those initial learning trials, but they're still able to get up to the control group standard for delayed recall. And so this is now, we have a clinical data set, we have a research data set that both replicate, or that replicates that clinical finding, even in a group not selected for cognitive complaints. Then we looked at this research data set that we have over 4 longitudinal time points. These are older survivors, 5 to 15 years post-treatment. A pretty good sized group, 328 breast cancer versus 162 non-cancer controls. And this was unique in that we gave them, we assessed them, I think it was every 8 to 12 months, something like that, over 4 time points. And so what I was looking at is, do we get that effect in that data set? And see, this is the NABLIS learning. It's just an analog of something like the CVLT or the HVLT, but fewer learning trials, which I think is important to the result. And then logical memory, which is the story memory from the WIMS. And again, what you see is this trial 1 effort, or this trial 1 deficit, right? And it's persistent, 1 to time point 2, time point 3, and then finally it goes away with time point 4. Initially, there's some kind of inherited deficit in long delay, probably through this and the shorter amount of learning trials, but that goes away pretty quickly past time point 1. And you see a similar pattern with logical memory. And this is even more pronounced, since you can see that it's significant, here it is not reaching significant, but still less than 0.1. And this is the simplified version. So this is just one of the stories that they hear 4 times in a row. And that's how persistent the difficulty is. What's interesting here too is that you have this consistent effect, and it shows that at least by time point 2 and 3, that they're able to compensate through repetition of that word list to not have a memory deficit later on. So they benefit from repetition within the study session, but I think there's also an argument to be made that they benefit from repetition across study sessions, for the fact that by time point 4, the effect goes away entirely. Now these are 2 different alternate forms, but still you're seeing that effect of repetition. And I think what informs us about research into this is that maybe repeated testing is not the best way to look at longitudinal data, or isn't the best way to look at the time course of these deficits in cancer survivors, because they actually might benefit more from repetition than controls. So when I was at Cornell, I started doing imaging there during a postdoc with David Silbersweg and Emily Stern, and that's actually how I got over to Memorial, through a collaboration with Tim Ollis over here. And so I was recruited to do some imaging work as well. And so this is work I did with Denise Correa, who studied stem cell transplant and looked at it before and after stem cell transplant in hematologic malignancies. And here you're going to see a pattern that's going to become familiar in terms of the brain structure of these dorsolateral prefrontal cortex areas here and here that seem to be predominantly affected for some reason. And one is chemo plus total body irradiation, where we irradiate the entire body, including the head. And the other is just chemo alone following treatment. You can see it's a very similar pattern of structural changes. And so this is a VBM study where we're looking at gray matter density. And so you see these reductions in gray matter density. This is a more recent study we did with a larger national group, Brendan McDonald and Andy Sakin and others, looking at longitudinal structural changes again in breast cancer patients this time. And these are heavily thresholded, so it's not to say that the gray matter thinning is that focal. It's just to say that when you femalize error correct it down to that level, that's what survives. But you're still seeing these, some temporal pole and also dorsolateral prefrontal cortex, middle to inferior frontal gyrus changes in gray matter density over time. I'm not going to summarize the other ones, but suffice to say, this is repeated over and over and over and over and over again, right? To varying extents, you see this gray matter thinning or gray matter volume changes, depending on how you do the VBM analysis. And they're all suggesting that dorsolateral prefrontal cortex, not only DLPFC, but a consistent finding is lateral prefrontal cortex changes in structure in the lateral prefrontal cortex. So one thing interesting there is that we know there's a frontal parietal attention network that is a core of it is going to be in lateral prefrontal cortex, and then it's communicating and mediating and modulating other areas in parietal, occipital, and temporal lobes. And again, you've got this overlap in this is kind of a schematic of the, kind of an optimized or classic kind of frontal parietal attention network. With these findings here, you might expect there's going to be an attentional problem, attentional control, working memory deficit. And remember that our learning problem that we saw on the list learning task seems to be a learning deficit, not a retention or retrieval deficit. So the interest then is to say, well, do we see anything functionally in functional MRI with our survivors? And so I'll focus, there's been a lot of different paradigms used, but I'll focus on the NBAC task here. And for those of you not familiar with the NBAC task, it's a working memory task we use it both clinically and in the scanner. That has 3 different conditions. Well, essentially 4, but 3 of interest. So that's a 1 back, 2 back, and 3 back. And what the subject is seeing is 1 letter appearing on the screen at a time, and they're to press if it's a match to a certain condition. So 1 back is just saying that the current letter is the same as the 1 back. A 2 back is that the current letter is the same as the 1 2 back from it, and the 3 back is the same as 1 3 back from it. So there's an increasing working memory load as you go through these conditions. And they'll see a block of 1 back, a block of 2 back, a block of 3 back. And importantly, it could be any letter. It's not just A, which it looks like in this case. It could be any letter that comes up on the screen that could be the same, that could meet that criteria. So they have to keep more and more working memory load in mind as they go through this task. And just to say here, the focus that we're going to look for here, what are we expecting to find with the functional MRI is really we're looking for task-related activation and task-related deactivation. So increases in either would suggest that there might be more compensation, and that would also reflect increasing effort in the task. So I think the intuitive approach here would be, well, you're going to look for less activation when they're doing these tasks because something's gone wrong in the brain. And actually what we see here is that more activation and more deactivation reflects more effort to perform the task. And so this is kind of a required slide in any presentation about this, because this is one of the earlier studies that was done by Rob Ferguson and Tim Ollis and Andy Sakin up at Dartmouth. And this is looking at identical twins discordant for cancer. And so the control twin is down below and the cancer twin is up above doing the same exact task. And this is all post-treatment. And so you can see that there's a lot more compensatory, what I would consider compensatory activation in the cancer affected twin than in her non-cancer twin. And so this is reflecting increased activation, increased compensation, increased effort, increased difficulty in performing the task than the twin not affected by cancer. And this is 2 people, right? So there's not much you can make of that, but it was inspiring to look at larger studies. And here you can see this recent paper from our group looking at, again, a similar pattern, but with many more people. I'm forgetting how many, but it's a large sample for an MRI study particularly. And what you see here is hyperactivation post-treatment in the usual suspects in the areas that you would think, like lateral prefrontal cortex, that overlap with these areas of gray matter reduction in performing that task. And this is a study that was from our group, actually early on, where we looked at the NBAC task again in breast cancer survivors from pre to post treatment. And just as an orientation here, what we can do here is I just showed you areas of task activation or hyperactivation. We're also interested in areas of deactivation as difficulty increases. So this is related to task difficulty, not difficulty for survivor versus controls. So it's just saying from 0 to 1 to 2 to 3 back, what areas of the brain reliably deactivate more and more and more when the task is on. And the idea here is, at least one idea here is that as task difficulty increases, the areas that are supporting the task increase in activation, and the areas that don't support the task deactivate or decrease as kind of a resource allocation, right? That you don't want to have that energy going to those areas that aren't supporting the given task. And so this would suggest that from 0 to, as the task gets more difficult, from 0 to 3, these are the areas that reliably deactivate, suggesting that they're not involved in the task at all. What we find, though, is in non-cancer controls, they exhibit reduced task deactivation at follow-up. So this is time 2 minus time 1, and you can see kind of medial prefrontal cortex to the frontal pole changes in deactivation. So they're deactivating less at time 2 than they are at time 1, suggesting that they have to reallocate or shift resources less so than they did the first time when the whole task was very novel to them. And what you see here is the breast cancer survivors are exhibiting the equivalent amount of deactivation. There's no difference in the amount of deactivation from time 1 to time 2. And it's reflect, I don't have the performance here, but it's reflecting their performance. So they don't exhibit a practice effect either. So the controls deactivate less, they appear to be less effortful in their performance, and also they exhibit a practice effect. The cases, the breast cancer cases in this case, deactivate to the same extent, and they don't exhibit a practice effect, which is going to be a kind of a common finding in a lot of the work. If you look at this research, it's not always a deficit, but it's a failure to improve and a failure to realize a practice effect. We also, there's a recent paper from Denise and us looking at resting state functional connectivity. So we've been talking about kind of focal or regional deactivation or activation, but we're also interested in, do areas of the brain start to become kind of functionally disconnected from each other? And so we saw within network kind of disconnection or lack of correlation between the central executive network, nodes of the central executive network, and also between networks, like the central executive network and, let's say, the salience network, suggesting that these areas are communicating less well with each other or less efficiently with one another, which could lead to cognitive and functional deficits. So the summary results so far, we have, the cognitive performance suggests learning deficits that might lead to later memory lapses or experience of forgetfulness, but not that there's true actual forgetting, that when the information gets in, it tends to stay in. And then there's structural changes in the brain that are consistent with those, with the areas that we would believe would underlie working memory and coding kind of processes. And there's functional changes in those similar areas that are consistent for or suggested for gray matter density decreases, and then functional changes that show increased activation, compensatory activation around those areas, and increased deactivation to support the task. So the gaps that we've identified so far that I'm going to get into now is that our standard neuropsychological measures might lack sensitivity, and they may lack resolution. And by the sensitivity, I just mean what I was saying earlier, is that if you have a certain amount of measurement error, which is to say, if you test someone now and you test someone in 6 months to a year, which we've done, if you had perfect measurement, you wouldn't have any change in performance, and we know that's not possible. But we looked at this in a reliable change index way for breast cancer study, and we found that in a lot of cases, when you look at the pretest reliability of our standard measures, that past a month, if you get to 6 months or to a year, these kind of more clinically relevant timeframes, they start to lose some of the reliability. In some cases, a lot of the reliability. And so what that's going to mean is it's going to limit what signal you can detect. If the noise is, 1 or 2 standard deviations, and you're looking for something that's about a half a standard deviation, the likelihood is you're not going to be able to detect that. And by resolution, I just mean that by the time, let's say, trial one of one of the serial verbal listening tasks happen and the person responds, a lot of different processes have gone on before we can actually measure the outcome, right? There's any number of things like sensory gating, pre-attentive automatic processing, voluntary or motivated processing, control of attention, and by that I mean really inhibitory control of attention, so dampening of your attention around the object you're trying to focus on. Could be just interference of later words with earlier words, and then again, this idea of disinhibition or inhibitory control of attention. And we can't detect that with our standard neuropsych measures, as good as they are in doing other things. And so at that time, you know, the NCI and we were going in the same direction, which is kind of fortunate for us, which was, well, so what's the core deficit here that is leading to these learning deficits? And we were proposing, and then NCI was starting to champion this idea as well, of using more cognitive neuroscience approaches and cognitive experimental methods to improve sensitivity and detection of cognitive changes in survivorship. And so this is not autobiographical because the online remote cognitive testing happened first, and then this other one I'm going to talk about happened second, but I'll talk about the other one first. So this is an R01 we started back in 2016. We're just finishing up our no-cost extension this year. And it was in response to this leveraging cognitive neuroscience to improve assessment of cancer treatment-related cognitive impairment. So it's kind of right on the nail for us. And what it was a call for is to develop neuroscience approaches, cognitive experimental approaches to more sensitively measure the cognitive difficulties in survivorship. And so this is the battery that we put together. There's some alterations in this now because we ended up swapping in one measure for another, but this we called our sensory attention executive battery. And it was meant to get at the most early elements of stimulus processing to later and more voluntary and motivated stimulus processing. So we use things like pre-pulse inhibition or using electromyography, used EEG and a paired click paradigm to look at P50 suppression. So this is going to be very, very similar processes to see are survivors screening out irrelevant or redundant information to the same extent as controls. We're using eye tracking to look at attentional capture. Does it take longer for a survivor to saccade over to a suddenly appearing target than controls? We use the attention network test. This is the Michael Posner GinFan flanker task that has different levels of cue information to look at both phasic alerting, also to look at shifting, engaging, and disengaging, shifting and engaging, and stimulus suppression or stimulus filtering in the case of the incongruent flankers. And then we also used a stop signal task, which is going to be the stop signal that comes on at varying intervals past a target, a choice reaction time target, to look at inhibition of response and inhibition kind of latency. And so the first thing is that what we found is two findings. One that was suggested of deficiencies in screening out irrelevant information and deficiencies in screening in relevant information. And so the paired clicks paradigm is a P50, we're looking for P50 suppression. So it's going to be, controls are going to show a reliably, or humans in general are going to show a reliably lower P50 response to a redundant click. So if it just goes click, click, they should show a larger P50 response to the first click and a suppressed P50 response to the second click. And so this is the ratio of the first to second P50 response. And what we see is that there is a lower P50 suppression for survivors versus controls. And that's the screening out piece, which is they're attending just as much to the first or to the second click as the first click. And then screening in, by that we mean this is a mismatch negativity paradigm where they're hearing a series of tones, and then every once in a while there's an oddball tone that comes on. And what you would expect is that there would be a greater N200 response to the oddball tone than to the repeating tones. What we see here is survivors have less of a response to the oddball tone, meaning that so together they're not screening out irrelevant information, and they're also not attending to or screening in information that is novel or is unusual or non-redundant. Part of this project also, we looked at N1 and P3 amplitude. So this is in the attention network test. And if you're familiar with that at all, there's cues that come on that tell the individual participant either nothing about what's going to happen, or there are two boxes that flash both at the same time that indicates when the target is about to appear, but not where. And then in some cases, only one on the left or the right box blinks, and that indicates it's about to appear and it's about to appear here. And then there's a whole subset of those that are invalid. So it would indicate the participant's going to appear just in a second right here on the right, but it's actually on the left. So that's valid versus invalid cues. And so with those varying levels of information, you expect to see, reaction time differences and potentially ERP differences. So up here you have pre-test versus post-test, controls and patients in red. And you see that before any kind of further treatment, you have kind of a similar N1 amplitudes. This is kind of the initial kind of salience kind of ERP component. And you have a similar N1 amplitude to valid and invalid cues for both patients and controls. Post-test, this is very early onset ERP. Post-test, you see that there's in this case, it's kind of tough to figure out, but this should be, the higher this is, the less of an N1 amplitude you have, because the scale on the y-axis is such that that's the case. The higher the number, the less negative. Down here you have, so you have this kind of very early finding of a deficient N1 amplitude. And then what you see at P3, the P300, is almost kind of an exaggerated catch-up for the invalid cues. So again, the invalid cues, the box flashes over here, says it's going to appear here, but the flanker appears over on this side. And so they have to reorient. And so what you see is kind of a deficient N1 response, very early response, and then almost an exaggerated catch-up response at P300 to complete the task. In our eye tracking studies, this is using, an eye tracking, an SR eye vision eye tracking device. We used a prosaccade and antisaccade task. And so the prosaccade task, as you can see over here, it's a very simple task. The participant fixates at the fixation, and then a target appears, and they're to saccade over to the target as quickly as possible. In the traditional antisaccade, the target appears, and they're to fixate away from the target when it appears to an equal and opposite space to the other side. And then this hat hanger or placeholder saccade is just that these three boxes are appearing. And so this gives the person a target to antisaccade away to. And we call it a hat hanger or placeholder saccade task. So this is the traditional, it's more difficult. This one's going to be a little bit of an easier hat hanger antisaccade. What you have over here is the time 1 and then time 4 controls, the patients time 1 and time 4. Time 4 is being used here because this all happened in the midst of COVID and the pandemic and the lockdown. So we couldn't do any of these measures for a period of time. So we kind of looked to the data where we had the most data, and that was going to be at time 1, certainly because a lot of that was collected before, and then at time 4, because we were able to collect that after things opened up. And so what you see here is the red is the hat hanger task, and then this kind of black dotted line is going to be the traditional task. Over here, you've got the same for controls post-treatment. Here it is for patients pre-treatment, and then here it is for patients post-treatment. And then the x-axis is is age in years. And this is directional error. So this is saying when they're in an antisaccade task and the target onsets, how often do they impulsively kind of go over to the target instead of moving away from it? And so if you've ever taken this test, it's pretty difficult because your prepotent response and our visual system's prepotent response, I think evolutionarily, is to saccade over to suddenly or novel appearing information. And so to move away from it takes a significant amount of effort. It's almost like doing the Stroop task and naming the color of the ink instead of reading the word. You can really feel the effort that is imposed on you to inhibit. And what you see here is that everything's kind of similar between time 1 and time 4 for the controls, including for the patients, although there's a bit of a greater difficulty here for the patients for the traditional hat hanger, where they're not given any support at all to saccade away from.
So Dr. Root, I'm going to have to interrupt because we're moving into Q&A time.
Oh, geez, I'm sorry.
Is it possible for you to wrap up so we can get to the Q&A?
Yeah, I'm sorry. I can wrap up.
Okay.
I think that after this, I was just going to talk about some future work, but yeah, I can wrap up now. I apologize for that. So just to summarize here, what you see is that in the unsupported head hanger task, older cancer survivors who are post-treatment are experiencing a difficult time in inhibiting their response away from the target. And so if you just to wrap up in summary, all these findings are saying that there's maybe some story here of kind of a inhibition and attentional control deficit here that's kind of common to all these different things, all these findings we're talking about, including initial encoding, including the N1 and P3 response, and including this eye tracking data, so that's kind of where we're kind of putting a lot of our efforts now, is into looking at inhibition of attentional control as maybe a core deficit in cancer survivorship. But yeah, let me wrap up there. I apologize for going over.
Thank you so much.
Sure.
So maybe let's see, let's get the screen back. And okay. So we're going to start the Q&A. Thank you so much, Dr. Root. Anyone has a question, please put it into the Q&A, and I will read it for Dr. Root. So the first one we have is from John Rosenfeld. It says, you describe results in terms of kinds of cancer. Do you have information in terms of individual chemotherapeutic agents? And are all your patients with the same cancer being treated with the same agents?
That's a great question. So our understanding of individual cancer agents or cancer therapies is not great in terms of chemotherapy. So, I mean, there have been studies out there right now that, for instance, taxane therapies are not more toxic or don't lead to worse cognitive outcomes in the TAILOR-X study, for instance. But, absent something like, intrathecal methotrexate or something like that, where obviously you have, blood-brain barrier, has access to the brain. Whether we're talking about adriamycin or cyclophosphamide or the taxanes or Taxol, we don't have great information about that. Most of in terms of the kind of homogeneity of the treatment, most of the patients that we see that are enrolled in our studies are getting a very typical like ACT kind of a protocol of chemotherapy. So at least there's that commonality. In terms of other cancers, I would say that the surprising thing is that we see these kind of similar findings in a lot of other cancers, both in hematologic malignancies, in colon cancer. And so it doesn't seem to be, I'm wondering if there's just a commonality of that cancer imposes of just increased chronic inflammation that maybe has a knock-on effect onto brain function, but it's not clear. I'm not sure if I answered your question, but.
Okay. So do we have any other questions? And people can also raise their hands if we don't have any in the Q&A. I guess I can ask something here. Do you have any suggestions or is there any research on ameliorative interventions? What has been helpful for these folks, both behaviorally, cognitively, and perhaps pharmacologically?
Yeah, so I would say the main thing that we recommend in cases where there's significant cognitive difficulties is kind of compensatory cognitive rehab. We haven't had a lot of great luck with direct kind of restorative rehabilitation, kind of really restoring function. It's mainly kind of prosthetic devices, offloading more cognitive tasks to your smartphone or your computer, writing everything down, having a to-do list, all the things you think about that are kind of compensatory in nature. We've tried, we had some interesting results with using transcranial direct current stimulation in a paper we published a few years back, but nothing in terms of direct. In terms of pharmacologic, the go-to, since I kind of think of this as an acquired attention problem, the go-to would be things like psychostimulants, if that's something that, depending on how imminent or urgent the difficulty is. And in some cases, the wakefulness promoting agents like Provigil and modafinil and those that we try if a psychostimulant doesn't work out for some reason. The rehab piece of this is it's not a great story, right? It's very difficult to get people back to where they were kind of on their own. It's usually with some kind of it's typically not as satisfying for them to having to do all these extra steps to perform the same task,
Okay, so there's some more questions. I have a question in the chat. I just want to remind people to please put it in the Q&A, but I'll read the one in the chat. It's from Joanna Festa. It says, I see similar subtle cognitive changes in post-COVID patients and find that typical neuropsych measures do not pick up these distressing changes. What other types of new measurements are being researched that may translate to clinical practice?
So hi, Joanne. Yeah, so I think I've been wondering about this, and I've been kind of jealous of Mount Sinai because you all are kind of at the forefront, it seems like, of looking at, long COVID, and I think maybe there's some cognitive studies going on up there. But I've been wondering if maybe there aren't more similarities than I think. And mainly with maybe the central commonality might be prolonged inflammation. And the subtle cognitive profile. So I sympathize there too. What I've found, over the years with clinical practice with clinically referred survivors is things like the CPT, the Conners Continuous Performance Test, for instance, has been really helpful because I think it captures what the deficits are in our patients, in that you see a lot of intra-individual variability. That's a finding that I didn't have time to do here, but that's a finding that I found in the Cog Suite online remote testing, which is the main finding you get is trial to trial inconsistency or intra-individual variability. And so because the Conners is kind of a cognitive experimental task that made it into clinical practice somehow, that's been a really helpful one to look at. Again, overall variability, but also the dynamics of variability and the dynamics of slowing as the task progresses. But that would be the one, so I'm thinking more of those kinds of measures of trying to, it'd be nice to incorporate those kinds of measures that have normative data to them into clinical practice.
Okay, great. So we have a few more questions. So this is from Esther McBurney Gog, and she says, hello from one of your former supervisees, Dr. Root.
Hey.
Are there preferred screeners for identifying these difficulties in our patients, given that many measures do not adequately pick up on them?
So like
a question. Yeah.
Like a self-report measure, or
do you want to answer that, Esther? You can put it in the Q&A or even raise your hand.
So I don't see anybody else on. I just see
Mine was answered just now with the last question, she says.
Okay.
So I think the CPT is what she responded to.
Yeah,
Okay.
yeah.
And then the next one is from Karen Wang. Thank you for the very, I see, rich presentation. Wondering, in addition to those commonalities of cognitive dysfunction across most cancer diagnoses, do you have any info on cognitive effects among glioblastoma survivors? Thanks again.
Yeah, so I don't. I mean, well, for the survivorship is so poor, right? Is the first problem there, and so and I don't really. My main findings are in non-CNS cancers. So Denise Correa, who's my neuropsychology colleague in neurology, really sees more of those patients and has more studies involving the primary CNS cancers. But again, the survivorship is so poor in those individuals that I'm not sure there's been as much research on those folks as others. I would say that it's going to be variable just depending on where the tumor arises and what it encompasses. But I don't have any direct research on that at this point.
Okay. All right. So do we have any other questions? We have a few more minutes. I have another question. Now this is a different time frame, but I have noticed with some cancer survivors, and I know that this is understood clinically, that you see really acute deterioration closer to death. So these are subtle findings that you have, but closer to death, you see really dramatic changes and also personality changes. Are you aware of the imaging findings behind that? Are there imaging findings? Are there any testing findings?
Yeah, so I'm not aware of them. Again, I think because well, particularly if you're getting funding, you want to, the focus is always on, look, the survivorship is really increasing in this group, and so this is going to be a quality of life issue for years to come. I mean, are you thinking more of things like, kind of frank confusional states and delirium, or more chronic cognitive changes as they get closer to death?
I guess what I've seen and what struck me is more behavioral changes, personality changes, poor judgment, poor impulse control, poor affect regulation, which I imagine has some frontal element to it.
Yeah, I would imagine so. I mean, we just haven't been focusing on we haven't been focusing on them because we're kind of going to where where the most years of survivorship and quality of life issues might arise. But yeah, I mean, in terms of our inpatients, we see it mostly in terms of delirium and thiamine deficiencies and things like that. So
I see. Okay. So we have one more question, and this is from Joanne Festa. It says, you mentioned that there are many factors that can contribute to cognitive changes post-treatment. I recall studies that showed chemo agents caused cognitive changes that persisted well after treatment ended. Do you still believe that to be the case, or do you think it may be other factors that are contributory?
So I can't rule out chemotherapy as one of the risks. We have to remember there's individual variation genetically and also just in age and blood-brain barrier permeability that could allow more access of chemotherapy and other cytotoxic agents into the brain. The main thing we see in our studies that are going prospectively, like in, before to after treatment, is there's not a huge signal of the chemotherapy. And really, we're interested more and more because it's just a focus on breast cancer is on these kind of chronic hormonal therapies that women go on, for 5 or even 10 years post. But I think the story of chemo brain, I think we have to kind of expand it to take into account everything else that the patients are being exposed to, including the cancer itself. And like I say, that kind of chronic inflammation that's been occurring over the period of time that the tumor has been developing. So, but these can be long-term deficits that, and when I talk to patients clinically, I say, look, I don't expect it to get worse. And I expect that as time goes on, it's going to get slightly better. I just can't say how close to pre-morbid function you're going to return, is my kind of advice.
Okay, so we have maybe 2 minutes left. If anybody we could fit one more question in. If anybody else has any questions. Okay, one more. Again from Joanne Festa. Thank you. Very interesting and informative talk.
Thank you.
Okay, so we are finished today. So for the attendees, the link for CE credit is still in the chat. It will be available for 1 hour after the talk. And to Dr. Root, thank you so much for a very important and thorough and sophisticated talk.
And overlong. Sorry about that.
No problem. There's a lot of details to juggle with these things, and
Yeah.
I'm always dropping things through the cracks continuously as well. And I just wanted to add that even those of us who are not neuropsychologists, we all deal with cancer patients personally and professionally. So this is really important material.
Great. I hope it was helpful.
Okay, so thank you so much.
Okay. Thank you. Have a good day.